into the chat for the recent speakers this afternoon, please do so. So while people are making their way up, Dr. Tonka, as you take a seat, I'm going to read an online question, and perhaps Dr. Barnett has some comment on this as well, but the role of cognitive behavioral therapy is obviously important for a variety of disorders. For people who don't have immediate access to a local psychologist or something, are there any online resources that you know about, or national resources that patients can get access to?
Yeah, that's a great question. In general, there are a number of states that allow pain psychologists to see patients over state lines. But I think I mentioned before, the majority of psychologists now, especially pain psychologists, will see patients virtually within the state. So if you don't have someone locally, I would search the state, and more often than not, someone within the state. But there are, it's called PsyPact. It allows psychologists to practice in certain states if you have a license in one state. So that's another option as well. It's not open to all the states, but it's something else to look into.
Okay, great.
Yeah, I would just add to that that there are multiple companies now that offer therapy online, usually through apps, and so it's probably the easiest time to be able to find a therapist now if you're willing to go beyond the traditional model of seeing someone based where you are.
Great, thank you. And again, don't be shy. I see a hand. I can repeat it if you want. So the question is regarding insurance coverage for these types of services.
I've seen a mix of models. Some of them don't take insurance, and you pay like a monthly subscription fee. But I have also seen some that are insurance based. So I think there's variability.
Don't be shy, everybody. Oh, one in the back. Don't want to make the walk. I understand. So to reiterate, the question is about patient hesitancy towards seeking care of a psychologist, or as I was speaking with Dr. Barnett earlier, even a psychiatrist. I've had a couple of patients in the last year saying that, I don't, quote unquote, don't want to see a shrink type of a deal. So are there any a piece of advice that you have in order to reduce or increase the likelihood that they're willing to come seek your services?
If there's a wife, talk to the wife. I think it can be very helpful to get family involved, to lean on patients in cases like that. But yeah, these are difficult situations. I think if a patient isn't open to coming to see a mental health specialist for whatever problem you're trying to get them to directly treat, if it's depression, something like that, I think it is helpful to sort of reframe things and talk about whatever other condition they're dealing with, and sort of highlight that in dealing with a neurological condition or something else, you're often also going to have problems with stress and anxiety and those sorts of peripheral issues that a psychiatrist or psychologist might be able to help with. I think that can be helpful if they're resistant to doing consultation for a particular mental health condition. Yeah, and I would say just if they're not open to it initially, keep revisiting that, and yeah, it can definitely be a tough situation. But yeah, I think those are probably the best piece of advice there is to revisit periodically if they've seen a mental health provider and had a negative experience. I see that sometimes too. Saying I did that once, I didn't like how it went. I would tell them that it's pretty standard, especially for therapists, to see 4 or 5 before you find one that you click with. And if you don't click with them, don't keep going. And so I would say go a couple times, but it really is that therapeutic relationship that determines outcome more so than the therapeutic modality. And same thing for psychiatrists. I would go ahead and give them the expectation that, they're probably not going to, fit perfectly with the first one they see. And it's okay. We don't take it personally when a patient comes to see us and we see them once or twice and we never hear from them again. We know that patients are out there, seeing multiple providers to find the right one for them. So, I would say normalize that for them.
If I can add something to that excellent response. Oftentimes when patients see me, again, as we discussed earlier, they're sometimes angry, frustrated, and there's a barrier that's been built up. They're sort of thinking, I'm just waiting for this person to tell me to like lose weight again and I'll get better. And so what I found is by, again, listening, that barrier comes down. And patients are much more receptive to options. The other thing I do at the end is I call it my little spiel, right? So there's things you can do for yourself as the patient. There's things I can help with. And I break down the things I can help with biomedical. So that includes medications, injections, surgery if needed, and the psychosocial. So seeing a pain psychologist or other members of the group. And again, I reiterate why that's important, how pain and emotion are two sides of the same coin. And again, if they have disclosed depression, anxiety, PTSD, bipolar, if those are not well controlled or not addressed, it's very difficult, if not impossible, for us to get control of the pain. But at the same time, I let them know, and again, as I mentioned earlier, pain takes control away from the patient, and the patients are desperate to get control back. So sometimes they come in and they're handing you these articles they've researched, right? And you're wondering, like, what in the world's going on? This is an attempt to get a sense of control back by knowing what's going on. And so I don't try to take away the control. I say, here are your options. You decide how you want to move forward, but these are all good options. And so you just sort of lay it out there for them. They may not be interested at the first visit, but maybe at a follow-up visit when you sort of go through the options again, they may be a little bit more receptive. And going back to what Dr. Barnett said about that, I sort of use the same thing. And many patients know this. I mentioned, for instance, anti-inflammatories. We know all anti-inflammatories work. They just may not work in you. So we need to sort of cycle through different ones if you're so interested. And so I mentioned the same thing about physical therapy. Oh, doc, I've done it. Well, maybe it wasn't a good fit with the physical therapist. Or again, with the mental health professional, maybe it wasn't a good fit. Let's try to cycle through, see if we can find a better fit and see if we can get it to work for you. Treating chronic pain is it's a marathon, not a sprint. Everyone wants it to be a sprint, right? The patient's there, they want that fix before they leave the office. But I explained to them, it's just a marathon. Today we're just stretching. We're just coming up with the ideas. And longitudinally, we'll be able to hopefully make some progress.
Yeah, okay. This is for Dr. Kinsler. Vitamin C, vitamin E synergistically are fairly reasonable free radical scavengers. So has work been done with that? Is that something that you suggested? They're fairly safe. They're fairly inexpensive, easy to get a hold of. Is there any role at all in recommending that? Or could you comment on it?
So I would refer you to that ALS Untangled site. Yes, there have been some small studies looking at vitamin C and other antioxidant kinds of medication or supplements in ALS patients that have not shown benefit. So vitamin C actually used to be on our list that we gave patients. It no longer is. Yeah.
Sarah, I was curious to know, as an APP who's integrated into a system that we have that hasn't had an APP with where you're working, what do team members, what do physicians do that make you feel really good about being a part of the team? And what are some things that physicians do that make you cringe or not feel so great?
That's a good question. I think, yeah. I think things that physicians do that I think make me feel a part of the team is, I like when I'm discussing with my staff a patient and maybe they get a sense that it's very complicated. And it never offends me if they say, like, would you like me to see this patient? 9 times out of 10, I say no, but I think it offers that they're not judging, that they understand that this is complex and they're there for me and we're working through it together. So that always makes me feel really supported. I think other things are, just being able to be included in the formal rounding process, being, asked questions just as residents are. It, keeps me on my toes, and, it also makes me feel like included and like I'm a valuable team member. Things that I don't like or maybe are harder are, and it really rarely happens, but things that maybe it's more that I see this happening with other APPs on other, in other roles, but being sort of like given kind of work that's maybe not clinical, like saying like, well, they can be the one to go get those images from that hospital where they're going to have to send 10 faxes and get CDs overnighted, and those kind of things. It's sort of like, well, I have clinical expertise. I'm able to see patients, so I think kind of having APPs only do that kind of work is not maybe the best utilization of that person.
Great, thank you for that. And we have an online question for Dr. Barnett. So, and I certainly have to plead ignorance on this. Vagus nerve stimulation for depression, a thing or not?
Yeah, I was actually talking to somebody about this in the audience earlier. So it's kind of an intriguing story. So I think it was in the early 2000s, there was a study looking at vagus nerve stimulation for treatment-resistant depression. And because they had noticed that mood improved in some patients with epilepsy who got VNS, and the primary endpoint, I can't remember exactly what it was, but it was a couple months after the implant, whatever is consistent with when epilepsy usually responds. And the trial did not meet its primary endpoint. However, they continued to collect data, and it looked like the patients with treatment-resistant depression got better after about a year. So there seemed to be some sort of delayed effect there. And the FDA, decided to approve VNS for treatment-resistant depression based on that. Unfortunately, though, then Medicare said, well, that study didn't meet its primary endpoint, and so we're not going to pay for that. And so it's been a challenge to get VNS for treatment-resistant depression. So it's typically not covered by, it's never covered by Medicare. It's rarely covered by Medicare Advantage plans. In Ohio, we actually have pretty good coverage through the Medicaid program, which has been surprising. But over the last few years, the manufacturer of VNS for that indication is LivaNova. They worked with Medicare to design a new study looking at VNS for treatment-resistant depression, and the agreement was that if the primary endpoint is met, Medicare would start covering VNS. And the results of that study, they're not peer-reviewed yet, but the company released a press release maybe a month and a half ago, and it said they did not meet the primary endpoint. So it doesn't look like the Medicare coverage issue is not going to change, at least for unipolar depression. I know they're still analyzing the bipolar depression data. With that said, I've treated a few patients with VNS for treatment-resistant depression. I can't say I've seen any home run responses, and so it's it's something that we offer patients, but I do try to really make sure we've exhausted other options, and really try to set expectations with them about what the device can do, and if there is an effect, it's going to take a while. It could be 6 months to a year. So it's it's not something I reach for quickly in these patients.
Great. And another question for Dr. Kensler. Some of the other neurodegenerative speakers kind of commented on the role of exercise, but certainly in ALS, the addition of the muscle breakdown and things of that nature add sort of an additional element on that. And some of these patients, as you mentioned, a risk factor is highly active people. So how do you counsel these people on exercise, activity, strength training, these types of things?
The short answer is that we don't know, and there are some ongoing studies. Generally, what I recommend for patients is the idea of submaximal exertion. So I don't want patients to try to exercise so hard that they're exhausting their muscles and potentially setting themselves up for additional muscle damage or loss because of that excessive exertion. So the rule of thumb that I give them is that they should be able to recover from whatever exertion they just did within 2 hours. If they're not recovered within 2 hours, they're still having trouble walking later in the day, their arms aren't working right later in the day, then that was too much and that they need to pull back.
Great, great.
Do you put all your ALS patients on medications regardless of how progressive is the disease?
Sorry, just to repeat the question for online. The question is about, do we put all of our patients on ALS medications regardless of the severity of their disease?
I offer medications. I'm assuming you're referring to riluzole and, and edaravone, those sorts of things. I do offer those medications, the supplements, including the ultra-high dose B12. I'll offer that to patients, but we will also need to have a frank conversation about what we can really expect out of these medications. Looking at a medication like edaravone, where you had to be fairly early in disease and really in pretty good shape to be able to show that there was a benefit, that suggests to me that it's not going to be very effective. And so it's got to be a pretty good, honest conversation with the patient and the patient's family about what our expectations can be. So the question is about for bulbar ALS. Yes, I offer the same disease-modifying therapies for bulbar onset patients.
I think there was a hand in the back, if you can speak loudly. So I think the question is about screening for fibromyalgia just in general.
Yeah, great question. Many of you are familiar with the tender point model of diagnosing fibromyalgia. That is out. Right now, the definitive way of diagnosing is that form, that 2016 form that does the widespread pain index as well as the symptom severity scale. One of the reasons for that was taking the bias out of clinician diagnosis. I think what was happening is when people were running out of explanations, they were saying, hey, you have fibro, when in fact they just had an unexplained pain syndrome of sorts. So there's no physical exam required to make the diagnosis of fibromyalgia. It's just that screening tool. And as I like to joke with patients, I just do some simple math. And so all provider bias is taken out of it. I just do the math, see what the score tells me, and then we talk about where it goes from there. Yeah, great question.
Do you find a rule for topical pain creams for your fibromyalgia patients, for those who fail oral medications, can't tolerate them? Is there any particular formulation that you like? Capsaicin over the counter, or diclofenac, or is there any combination cream that you use?
So the question is about topical, basically pain regimens.
Great question. So the data suggests topicals aren't particularly effective just across the board. That being said, if you look at the data for most of our medications for chronic pain, they're also not effective right across the board. So it's the same thing I mentioned to patients. This might be an option, especially if they have a systemic issue with, for instance, NSAIDs, Voltaren gel. Great option, right? All the topicals have minimal, if any, systemic absorption. Good option. But I have not found any specific formulation to work well. When I started off earlier in my career, I worked with a compounding pharmacy, and we just started with 3 medications, and we tried different concentrations and just sort of everything under the sun to try to break this code. There was no rhyme or reason. It just, patients may respond, patients may not respond. And so I let patients know that ahead of time. Oftentimes it's also an out-of-pocket expense as the compounds get a little bit more creative. But as of right now, but again, all of us have probably run into the patient who says, like this, and they'll give you the compound that worked well. I have no problems refilling it if they know it's worked well, but otherwise it can be a very long and expensive process to find something that they tolerate. But they're safe.
Great, thanks.
Yeah, question was about marijuana. So I think this is a Cleveland Clinic thing. So the official Cleveland Clinic response in terms of discussing marijuana is we don't discuss it currently with patients because there's not enough evidence to suggest its utility, and we don't know its safety profile. That being said, when I was at my prior academic institution, I was the marijuana guy, and I used to give talks about it. And again, interestingly enough, my talks are basically the same. We don't have enough evidence to suggest one formulation, THC, CBD. There's an issue about whether or not what you're actually purchasing is truly the percentage. they're mentioning. And so again, many patients will say, "I tried this, it doesn't work." And you don't really know if they got what they purchased, or if another concentration will work better. So just like topicals, the patient has time and money, you can try, but I haven't found anything that I could recommend.
The state of Maryland, the state sanctions these special marijuana clinics actually, so you can actually go and see these physicians, and they do come back and say, yes, it works. I mean, these are not, your marijuana they buy off the streets. These are actually, like, I don't know, in Cleveland and Ohio, do you have like the state sanctioning marijuana clinics and stuff? They do.
Correct. But right now, I think until there are actual studies that show the utility, I think we're hesitant to recommend. The last, I think it was, were you at that site grand rounds where two addiction fellows, they sort of went over all the data we currently have, and there's just not enough data to recommend it. There is some data suggesting potential harm as well. So, but until there are more widespread studies, I think the official response is no comment. I'll let him answer that.
Yeah, I mean, I think it certainly can temporarily. I'm not sure it's a long-term treatment that you want to recommend, though.
I have two questions. One for Sarah. The terminology APP is somewhat of a mouthful. Advanced practice provider. Is there any discussion as far as, I think in London and England they have used the term AP, which seems somewhat shorter formulation. I think their AP stands for associate provider or associate practitioner. Has that been any discussions regarding that?
That's a good question. I haven't heard that term before in the U.S. I have heard mid-level used before, which has had some pushback in like the advanced practice provider community, just because it's, I don't know, they feel like it has this connotation, I guess. I haven't heard the term, you said it was?
Associate provider.
Associate provider. I haven't heard that. I guess it's a good question. I think advanced practice provider just sort of encompasses such a large group of advanced practice registered nurses and PAs. So I think that's why the Cleveland Clinic uses it, but I'm not sure, and that's what I see in most of the literature, but I do know that mid-level is still being used at some other facilities.
I think Medicare has a different terminology. I believe they have, their terminology is independent.
Licensed provider.
And then they have,
Yes.
I think, dependent or something like that.
Yeah.
The other question is regarding the use of glutamate inhibitors or medication like Fycompa for pain. Is that something that's been tried since, especially fibromyalgia, where there seems to be an increase in dopamine, in NMDA or glutamate?
Currently, no good studies suggesting its utility. Not to say it won't be used, likely off-label or in the future, but right now, nothing to suggest using it.
Great. Well, if we don't have any other questions, then I will give everybody 5 minutes of their time back. But again, a round of applause and a thank you to our recent speakers. So as a reminder, again, part of this 5 minutes, hopefully to remind you there are several non-CME sessions remaining, one of which starts in 4 minutes. In the Jefferson room, as a reminder, it's down to the left, then it's down to the right. There's arrows pointing the way. Follow that. Today, again, starting at 4:10, we have Takeda presenting HyQvia, a management approach for adult patients with chronic inflammatory demyelinating polyneuropathy. And then for those of you who are early risers like myself, the final non-CME session will be tomorrow morning, again in the Jefferson room, starting at 7:15, sponsored by Neurelis, talking about rapid, reliable, ready seizure rescue for episodes of frequent seizures. Again, thank you for your attention and enjoy your evenings.